Dr. Malcolm Bell, and this is a lecture which every interventional cardiologist should be interested in.
Yeah, thank you very much. I'm just going to start off just firstly publicly thanking Dr. Patel for, again, giving me the privilege to participate in this fantastic meeting. It is an important topic here, interventional health, so maybe I could just ask you to pay attention for a few minutes here rather than trying to follow that cricket match that's currently on, I think, India and Pakistan. So when I see your heads go down, I know that you're tuning out. So I'm not sure who I'm going to be supporting here. So I'm going to be talking about three things here. First of all, radiation safety. Next thing, orthopedic issues. And then the third would be mental health issues. So let's talk about radiation just briefly. And we could spend 30, 40 minutes talking about this, but the reason we wear protective aprons is we want to protect ourselves from that supposed, increased risk of getting a malignancy. And so let's just put this into perspective. In today's environment, in today's cath lab, if you've got a properly tuned modern X-ray system using all the bells and whistles, adjusting frame rates, input doses per frame, your radiation exposure should be very minimal, and particularly if you're using protective shields, so ceiling shields. The ceiling shields that I didn't see today, from the ceiling on the floor, you must use those because your risk is going to be very, very low, particularly for the young ones in the audience. You have an advantage. I didn't. I began my training in a time that no one was telling me what about radiation safety. The X-ray systems were just belting out huge amounts of radiation. And of course, I was wearing a lead apron that was about 10 or 12 kilograms in weight. But just putting this in perspective, where do the risk assessments or estimates come from? They come from the Japanese A-bomb survivors, okay? It's an unfortunate thing that we have to look at, but this is really very helpful. And if we look at 100 millisieverts, this is your effective dose equivalent in a year, that we may get 3 or 5 millisieverts if we're using the appropriate protection and using those ceiling shields, etc. And for a low volume operator, your lifetime exposure, let's say over 30 years, may be around about 100 millisieverts total, which will give you an incremental risk of cancer of less than 1%. There's always a background risk of cancer. On the other hand, if you're a high volume operator and you are getting up to 20 to 30 millisieverts per year, now your risk does go up, but it goes up to about 4%. And in the United States, the annual limit is 50 millisieverts per year. In Europe, it's 20 millisieverts. I don't know what it is in India. And if you don't know what your effective dose equivalent is you're getting every year, then you need to talk to your radiation safety officers. You need to know what your dose is. So this is just really put it in perspective. Now, a few years ago, there was some concern about the risk of having brain cancer or brain tumors from radiation. This was just self-reported. It wasn't a scientific study at all. And I'm just going to sort of summarize this there, that very careful estimates that we've made with our medical physicists in our cath lab, and Dr. Galati and I've been involved with these studies, is that your brain dose over time would be about 120 millisieverts. Meningiomas may develop if you're getting 1 sievert or 2 sieverts. This is for radiation therapy. So we've got thick skulls. Think about that. You're meant to laugh at that. But we have thick skulls. That protects us from the radiation. And so here are some estimates here of 10,000 interventional cardiologists. A fatal brain tumor may occur, 25 from natural incidents and 4 from occupational exposure. And another group have estimated that you need to do about 2.5 million cases before you really put your brain at risk of developing a tumor. Now, this is serious, though, because anyone know what this is? It's the optic lens. This is probably the most radiation-sensitive organ in the body. And I just want to bring this to your attention. We've been complacent about this over the years in terms of protecting our eyes, but safe radiation absorption to the eye, there was the threshold dose had been lowered to 500 millisieverts. That's a lifetime exposure. And interventional cardiologists can easily reach that if you're not wearing eye protection. And so again, I'm not sure I saw a lot of eye protection in use today, and I think that's maybe an opportunity for that. But now the dose limit has been lowered to 150 millisieverts per year. This is a huge, from 150 to 20 millisieverts per year. And interestingly, at a survey at Scolassi a few years ago where they did slit lamp exams on interventional cardiologists, they found that 50% of them had lens opacities. And the most concerning thing is that more than half of those interventional cardiologists were never wearing eye protection, and furthermore, they had no idea what their annual dose exposure was. So I think there are lots of learning opportunities here. And so we should wear them. They're lightweight now, and we should be using those routinely. So, of course, then we protect ourselves from radiation. And as I said, the risks are relatively low. And I don't have time to talk about getting rid of lead aprons or protective aprons. Of course, they don't have lead in there anymore. They're not really lead. But let's just think about what we do. We wear these protective aprons. And I think that there's hardly anyone I know in the interventional community, and certainly among my colleagues and friends, who has not had orthopedic problems, whether their neck or their back, have had to have intervention, surgery, or have lost days at work. It's very prevalent. Now, we protect ourselves, and it's interesting. Sometimes protection comes at a pace. It's of unintended consequence. Here was a very famous battle about 500 years ago between the French and the English. And this is the Battle of Agincourt, which the English won. The French had far superior numbers, but they dressed them up in very, very heavy armor because they wanted to be protected from weapons. Except that the field was very muddy. The battlefield was muddy, and they couldn't really move. And the English archers, they destroyed them and unexpectedly won the battle. And this is, again, one of those unintended consequences. Here's another one. This is American football. Decades and decades ago, American footballers did not wear helmets. And they started wearing helmets because of skull fracture frequency. And so they basically stopped skull fractures occurring in these games, in these collisions. But the unintended consequences now is that the head and the brain are floating around inside this, and you get this chronic traumatic encephalopathy, and it comes from the helmets. Here's a study done by one of our fellows and one of our colleagues, Dr. Mandeep Singh. It looked at this was a very carefully conducted survey of workers at Mayo Clinic, and showed that radiation workers with matched controls, employees at here, over 1,500 of these, were much more likely to have work-related musculoskeletal pain than those controls. Now let's think about some of the ergonomics in the cath lab. Do you ever think about this? Are you standing with a good posture? We're wearing these protective aprons. We're leaning forward, doing strange things with our hands. We twist around here to get something off the table behind us. Here we are. This is the force between the the intervertebrates of 2,000 kilopascals. And what about this one? This is actually a sad case. This is the Sperling's test to diagnose cervical neuropathy. And you see what he's doing. He's bending forward and lifting his head up to look at the monitor. And sadly, this is one of our fellows from many, many years ago who recently developed some quadriparetic symptoms and has had to step out of the cath lab, something that could be life-changing here. And it's just a coincidence that I took this photograph of him all these years ago to demonstrate this. I have to keep telling my fellows, stop bending over, stop leaning over, stand up straight, get it in the right position, be aware of your ergonomics. What about this? How often do we see people lifting their head up to look at the screen because the monitor's too high? And we know that from biomedical engineers that as soon as you start extending your neck up there, that force to C2 rapidly increases. So you should have the monitors at a angle that you don't have to lift your head up or bend over. And so be aware of these things. So the final thing I want to talk about is burnout. Burnout among physicians, unfortunately, is increasing, and it's at alarming rates. And these are data predominantly from the United States and some from Europe. I have no idea what's happening in India. It's getting worse. Depression is increasing, and we should not accept this as the normal. We definitely should not accept this as the normal. And what is burnout? Burnout is not because you've been busy all day and you're tired at the end of the day and you're mentally fatigued and physically fatigued. It's a triad of symptoms where you have emotional exhaustion, a sense of depersonalization, and a sense of diminished accomplishment, that you're working hard, no one really cares for you, you've got no control, and you're just another cog in the wheel here. And there's a survey that comes out every year in the United States. They survey about 10,000 physicians across the country, multiple specialties. And here was the title of the one from a year ago. And isn't that a heartbreaking title? I cry, but no one cares. And here are some data from the most recent one from last year. Burnout was seen in almost 50% of the respondents to this survey. 20% reported depression. Women were more likely to be burnt out than men, but these were still high. The people who have the highest burnout are the physicians who are on the front lines. Do I have your attention yet? Yes. Okay, good. We can put the cricket match on pause, okay. I just bring that up because this is a serious thing, and I don't want to make too serious, and we've still got to have you enjoy yourselves here. But emergency medicine, 63%, oncology, and lower levels here, cardiology, 47%. But who thinks that 47% is acceptable? It's not, is it? We didn't sign up to be burned out here. Other key findings. It's not just the old people because they've been in the business a long time. In fact, it's frighteningly frequent among younger physicians or even medical students. These are really important things. So, in fact, the younger physicians are more likely to report it than the older ones. And it's concerning that almost 50% of them already had it for 2 years. It hadn't gone away. It really impacted their lives, emotionally. You can see there how they tried to cope with this. And depression, as I said, was 20%. Most of those were just, someone said they felt depressed, but 25% of the patients with depression, this was clinical depression, which required treatment. And here's the saddest thing of all. Look at this title. We see this not infrequently in the United States and the United Kingdom. And here, this title, she thought she would have to kill herself. She didn't, she failed, but her friend did succeed, died by suicide. 400 physicians every year in the United States die by suicide. So we have to graduate 2 medical classes of 200 students to replace the physicians who died by suicide every year. It's an astonishing fact. What about interventional cardiologists? I'm talking about physicians in general and some in cardiology. Let's just think about our work. It's a really gratifying career for most of us, and it should be for all of us. But we recognize that it's demanding work. We got high-risk patients. I mean, look at some of the cases. We started off yesterday where the patients almost died, and there are high stakes here. The second victim syndrome. Everyone knows what the second victim syndrome is? That's where something's gone terribly wrong, and you feel as though it's because of your care or lack of care or a mistake or something that you've made. And we don't take good care of our second victims, typically. People are left to sort of dwell on their perceived errors by themselves. We have long hours. Never underestimate the stress of being on STEMI call all the time, sleep deprivation. But on the positive side, look on the right side. We're working in the cath lab. We're not there in the clinic, seeing patients. We're doing the things that we were trained to do. We love using our hands. There's less clerical burden with this. It's a great field, isn't it? It's really exciting. It's rewarding. There's lots of innovation. And you're the team leader. You're in control. You're responsible for everyone in the room. A lot of responsibility. This is a great job to have. But we don't want that to be destroyed by the other things on the left-hand side here. And what are the contributors to this? And I'll try to finish this up very quickly here. The institution and the system, at least in the United States, there's too much bureaucracy, regulations made by people who are not physicians, and they think they know what's best for us, and they make us jump through hoops and do all sorts of courses and paperwork. Lack of respect from co-workers. We see that. It's not the same as it was 20, 30, 40 years ago. The burden of on call, which I've already mentioned, the electronic health record, as we say, death by 1,000 clicks. And there's a lack of control, outside interference, and we don't have a system that really helps us navigate these burdens. Safe travels, TAC. And what about patients in society? And I'll just finish up with this here. There's an unprecedented demand for doctors' services. We are unable to meet all those medical and particularly social needs of our patients. Our patients come in the hospital and they've got more and more complex disease. They come in with a lot of social baggage as well. And there's a higher burden of chronic diseases. We're seeing older and older patients with more chronic illnesses, particularly cancer and lung disease. And what about the rise in threats of violence from patients and visitors? In the United States, if you work in the healthcare field, that's where you have there's more violence in the healthcare field than almost any other field of work in the United States. And that's very, very sad and very scary. And we're well aware of our polarized society, particularly, as I said, in the United States, and people attacking the science that, that are the very foundations of what we're doing with our patients. You're not unaware of this. And you're really concerned. I see this in headlines from time to time, but I don't have to read that for you. You're aware of this, and it's a shocking statistic, and it's something that we should not be standing for. And so, in summary, we cannot accept the status quo in terms of burnout. In terms of solutions to this, they're long overdue. And our healthcare organizations, our hospital leadership, our clinic leadership, university leadership, they have to take responsibility for this and change the system. And this should not be the norm. We should not accept this. This is totally unacceptable, and it's dangerous, not just to us, but to our patients and healthcare in general. And I'll just finish by saying that, well, what can we do to remain healthy? And I've told you what the source of all these issues are, but just think about this. I think you need to as physicians, by the way, we're not very good at taking care of ourselves. We tend to ignore things. We don't go to see the doctor. So I think it's really important that we take care of our physical health and mental health, be aware of these issues, spend time with your family, more time with your family, your friends, have that support system. And look out for people who work with you, your junior residents, students, your colleagues, who you may think are doing just fine, but look out for the warning signs. Be there to support them. And then in terms of the physical issues, I already mentioned there, be fit, be strong, and just keep in mind that there are risks of working in the cath lab, but I would argue it's not the radiation risk, it's the orthopedic risk, and then, as I said, the mental health issues. So thank you so much for your attention, and thank you.
Thank you, Dr. Bell. That was one of the most elegant and eloquent presentations I saw on keeping interventional cardiologists healthy. Dr. Patel, Dr. Tejas Patel, could I have your perspective and comments on this particular subset? So, just your viewpoint.
Like to invite, I am giving him invitation, Malcolm. Next time we will have question answer on this for 15 minutes rather than your talk, or 20 minutes. Because many people will have many questions, and I cannot think of anybody better than you to answer them. Thank you.
Thank you. And on his point of orthopedics and low backache, just one input for the entire audience. So I'm Brigadier Sanjeev Sengupta, I'm from the Armed Forces. And Bhujang Asan. So sir mentioned the cruise tent made in India. Bhujang Asan, it's the cobra pose. It's one of the most effective things any interventional cardiologist can do for his spine. Just look it up on YouTube, and thank you so much.